The third session is Pharmacy Practice. Will be chaired by Professor Hisham Al-Jadai, Supervisor of Pharmacy Service, Intern Dean, College of Pharmacy in King Saud University on Kingdom of Saudi Arabia. Professor Al-Jadai is a member of the International Expert Group of Patient Safety Research in Primary Care in the World Health Organization, published more than 100 peer-reviewed publications. Please welcome Professor Hisham Al-Jadai.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone, and I hope you are enjoying the conference. First of all, I want to thank the organizing committee for inviting me for this conference again, and especially Dr. Sara Al-Blushi. I will start with the session with my talk, and then we will have another 2 talks, and then we'll have the lunch, and then another 2 excellent other presentations. So in my presentation, okay, let's see. So what I'm going to talk here, actually, a few months ago, 6 months ago, I started with a new task of directing a pharmacy service in a teaching hospital at King Saud University. And I had a lot of challenges and successes and thoughts and stories with that. And I thought I will share these with you and also get from your comments and your feedback on that area. By the end of this presentation, we'll be able to discuss the need for another model for pharmacy in teaching hospital in our region, in Gulf region, discuss the existing models, and also evaluating a current practice model that we have and suggest some changes. So my first question for you, how many of you are pharmacists working in a teaching hospitals? 2, 3, 4, 5, okay, 6. So, and how many of you that are practicing, you are in Oman? All of you? Okay, in Oman. And, okay, so it's challenging. A smaller number of you in a teaching hospital. However, we have ideas for that in teaching hospital and may apply to other hospital as we move forward. Why we need a new model for teaching hospital? I think the current model and the practice what we have is focusing on service first, and the establishing of these hospitals for the purpose of teaching, purpose of education. So we are focusing on service now. We have a huge shortage of pharmacists in hospitals, and I can talk about this at least in Saudi Arabia. We have a huge shortage of pharmacists, and we cannot, we have a lot of positions, we cannot fill them in the right time, so we will need help from other sources. And again, teaching institutions or hospitals are well established for the purpose of education, and involving students is important. Research is a major component in a university hospital, and as some speaker talked about this this morning. Innovation should come from, university-based healthcare system. That's my expectation, but you can challenge me on this point. We have a huge need for student training. We have more than 27 pharmacy colleges in Saudi Arabia. And for example, at King Saud University, we have a class of size of 200 students per year. And we have a huge shortage for sites, training sites for IBBE or ABBE. And our system, current system for training is not working. Basically, it's not working. It will not work once all these schools will work in full capacity. Other models, and if you look at the literature search, you see a lot of different models, especially in North America. They have models for teaching hospitals and including student training there. However, didn't find published literature in the area, especially in the Gulf area. Basically, these models focus on the involving student more in what they call layered learning model. That's one thing. The other thing is to expand the pharmacy services that you are providing, and some of these services, including like medication history, discharge counseling, will be done completely by students. One example in the Greenville Health System in South Carolina, and I borrowed this slide from Fred Bender, who's the director of pharmacy there. They had the integration of B4 students into the pharmacy practice model to do medication history, patient education, reconciliation, and discharge, and also pharmacokinetic and anticoagulation. And now in their hospital, they are running full service, 100% run by students. And they have at one point of time from 8 to 12 students to run the service for their hospital. In addition, they are asking students to come on a weekend basis to cover all these services. In the University of North Carolina, and again I borrowed this slide from Steve Ickel from UNC, they have this, a similar model where they have the pharmacist and also they involve the resident to have other duties under the pharmacist. Then again, they have the students. So they have both two model with the layer model. Now I looked at these models, and also there are other models existing in different university hospital in North America. Now I will move to King Saud University Medical City, and it's a case example for a university hospital in the Gulf region, and what our challenges and how we are moving from that, and how we can get a new model for that. So I will mention about the current practice and the vision and the model to accomplish this vision and organization structure, some challenges and accomplishment, and some future. So for our hospital, we have King Khalid University Hospital. At this moment, it's 1,000 beds. However, it's expanding within less than 1 year to 1,400 beds. We have King Abdulaziz University Hospital, 150 beds, but also expanding within 1.5 years to more than 300 beds. King Fahad Cardiac Center, now it's with the KKOH Hospital. However, we have it, big buildings will start in January 2016, a heart hospital with 160 beds, including also an ICU for cardiac patients. And also we have a university diabetic center, a national diabetic center, and the total will be within 2 years, we will have 1,800 beds for all the hospital. In addition to that, we have a dental hospital where they have also admission, and a pharmacy will be there too. We have outpatient pharmacy in several places. We have in our main hospital about 5 main outpatient pharmacy. They dispense more than 4,000 prescriptions per day. We have in King Abdulaziz University Hospital another 3 pharmacy. We have in the campuses for students, we have several pharmacy in the campus for the students, and also for the student housing, and also for the staff housing, we have pharmacy and clinic there. And student housing for the also for the boys and girls for the campuses, and another one for preparatory year pharmacy. So we have about more than 13 satellite pharmacy in other clinics that we are supervising. Our budget about 500 million real per year, and we have more than 1 million outpatient prescription per year. And in terms of the staff, a few months ago, we had about 80 pharmacists and 10 administrators. And if you can just calculate this only can help us with the outpatients, nothing with the inpatient. If you calculate at least like 120 or 150 prescription per pharmacist. So we had a huge shortage of staff, 100 pharmacy technicians and 9 clinical pharmacists in this area of specialty. So the vision, we wanted to move from the focus on the surface to add the education and the research. And this is the vision for the medical city, for the higher administration of the university, is to move the university, hospitals, and the medical city from focusing on the surface to include the education and research, and to support this within each department. So to get to that, I think there are major component that we wanted to move forward with it, to integrate the surface, the people doing the surface operation with the clinical pharmacists, because there is they are not talking to each other at all. The clinical pharmacist in another place, and they are doing different what the operational pharmacist is doing, and this is not helping the patient. Also incorporate student training within and integrate it within what the daily work for the pharmacist and the clinical pharmacist, and have them do the work themselves. They actually used to do shadowing only and the observing. Or sometimes they will do for them lecturing. Sometimes they spend 2 weeks out of 4 weeks in their ABBE just getting lectures in the hospital. And that's not helping the student or our clinical pharmacist. Automation, we need to use it fully, basically for the safety of the patient and then for the efficiency. So we thought that the key component for leading a pharmacy department is really recruitment and getting the right people, either fresh graduate or the people with experience. And I think that's a key component, recruitment and retention of those you are getting. Automation and getting the fully automation from A to Z, from getting the drug to the hospital until administered to the patient. That's very important. At this moment, we don't have any automation in that hospital. Space is very important to make things working. And around this policy and guidelines to keep us on track, I think it's very, very important, either for the pharmacy department or for the hospital itself. I started with this organizational structure. As you can see, I have for the director of pharmacy, I have about 11 people or 12 people reporting to me, and that's a lot for me. And we had the assistant director for inpatient, for outpatient, for quality, for clinical service, and also for other satellite hospital, we already have an associate director, so they're working independent from the main hospital. Then in that hospital, we have a lot of people administrative. We have supervisor for inpatient, outpatient. They are doing admin job. So that's a lot of wastage of pharmacists. So we are proposing a new structure for the department, where we will have deputy director for support services and also director or assistant director for scientific advancement, or basically for research, and the other one for education, or what we call professional development. And then another one for operation, which will include acute care services, ambulatory care service. And the clinical, the idea is the clinical will come under the acute care service or under the ambulatory care service. And then for each hospital, we will have a supervisor for that outpatient or inpatient pharmacy there. By this, we will have on those who are reporting to the director, we will have people from education, for research, and for operation, and then this will send the message to all pharmacists and all people that we are really valuing all these three components in our vision and our application. So we started with some initiatives, and we're trying to put like a master plan for it, so to make sure that we are going to the right direction, and also to have a timeline for these and an action point. One of them is pharmacy automation and starting a unit for pharmacy informatics and automation, and mail pharmacy, and this for pharmacy automation, we just actually, tomorrow morning, we will hire the first pharmacist in that unit. Mail pharmacy and delivery, especially for our satellite campuses, The drug availability and shortage is a huge problem that we have, and we wanted to get a curative action for it. Ambulatory care pharmacy and counseling is an important one. Educational training, BNT committee and developing the process what we have in there, acute care pharmacy and improving the operational level of that, and expanding the clinical pharmacist, and also for the strategic plan. So I think for the challenges, I summarized some of these challenges, but I think the key component for me, I look at it as a director of pharmacy, is the recruitment, is the challenge, to find people. I have positions, and it's very difficult to get the people, and very more difficult to get the right people, and much difficult to keep those people. So the idea to get those people is that I tell them that you have the opportunity for education, you will precept students, you can participate in the school to teach, also will give you protected time to do research, and we want to support you to do that. This is the way we can market the hospital and get more good pharmacists to join us. And creating a culture of work and a good environment is a key component and very important, and that's where we will keep our people. Outpatient pharmacy in Saudi Arabia and in many hospitals in the area, we are doing a lot of dispensing without counseling, and also we have a large number of prescriptions. We have more than 3,500 prescriptions in one outpatient pharmacy, and the waiting time was more than 1 hour, was 1.5 hours, the average. So that's a huge problem, and this is bring the administrator of the university, the rector, and the CEO of the hospital. This is a big issue for them, the waiting time. Drug availability and also delivery and getting it to the in the right time to the pharmacy is a major issue. We have a lot of medication out of stocks. Information technology and automation is important. What we tried to do within the last 6 months, we increased student training. We used to have few pharmacists just doing training for students. We had those pharmacists all working, and then we had every pharmacist to participate in the training, and we asked the pharmacists to leave the student, do the job themselves, and just they supervise them. And this is very tough to change, because people, they are used on the system of that they are teaching the student and they don't let the student do the work by themselves. Recruitment, and the number changed. I just changed my slide this morning, and actually after my changing the slide, I have another 2 pharmacists just joined us this morning. And other clinical pharmacists will be doubling the number of clinical pharmacists. Actually, we joined attended the ASHP mid-year in Anaheim this year and had a booth there, and we were able to recruit people from there. So successfully, we are getting commitment from 5 people to join us. My goal will be higher than this, but we will continue. We'll go to next year to New Orleans also to get people from there. So I think we are getting good quality clinical pharmacists from that trip. 16 continuing education hour, and we are looking for that to also include ACB accreditation for these continuing education in the near future with the collaboration with the Saudi Pharmaceutical Society. We just established the unit for pharmacy informatics and automation, and also we will have a unit for research to do the statistical analysis and the data collection and to support our staff. We will have the ACCB assessment visit in March for clinical and also administration and operation, and come up with suggestion for that. Just in the outpatient waiting time, we had some changes we added more pharmacists and some changes in the administration. And as you can see, within 5 months, the waiting time improved. We have now more than 90% of the patient within 20 minutes, and almost 98% within 30 minutes. But that was really of changing the work and also relying on about more than 10 pharmacists, fresh graduate pharmacists, working in the outpatient pharmacy and giving them the trust and that they will make the changes, and they were able to do to make a big difference. I think future will be automation, scholarship, and sending as many as possible for our pharmacists to get their PharmD residency from North America and others to get their residency from Saudi Arabia. Then also continue recruitment, and it's a very difficult job at least in the Gulf area. I mean, there are a lot of employers who are looking for pharmacists. And also expanding the training to include it in different other areas that we didn't include. So in conclusion, and this is my last slide, I think we need a new model for teaching hospital where we include training as part of the service. I mean, we need to look at our operation and take as many as we can from our operation to the student to do while supervised by pharmacists in this activity. And I think if we move forward with this, we will be able to find good training for our students who are the future pharmacists. I think there are a lot of challenges to implement any model like this or any way of getting the student, giving them more opportunity for practice, and especially the challenges from your staff pharmacists. And you need to work with them slowly and also show them a model, show them example, and get them other experiences. And that's why we are actually conducting a symposium in April to look at how we can do this, and inviting some people from different hospitals to tell our teams and visit with them within the hospital about this idea and how they can implement it on a daily basis. And also the idea from this is to bring the College of Pharmacy with the pharmacy department. So we will have faculty member go and practice, which we don't have a lot of them going, and also at the same time have our pharmacists to accept training those students. And also participate in teaching didactic in the college. So this activity will be, all of them will be all together, and I will invite anyone from the audience who are interested to attend this symposium to please come and join us. And by this, I will end my presentation, and I will move forward to present, to introduce the next speaker. So our next speaker is Professor Mariam Bini. She's the Professor of Pharmacy at Strathclyde Institute of Pharmacy and Biomedical Sciences, University of Strathclyde, Glasgow, from the United Kingdom. And she will be talking about development of an infection intelligence platform in Scotland, supporting clinical improvement.
Thank you. Can I first of all thank you very much for the invitation to Oman. This is my first time in Oman, and it's lovely to meet as many people who have actually been to Glasgow in Scotland. So thank you for that invite. I've been asked by Sarah and the team here to talk to you a little bit about some work that we're doing in Scotland in looking at how does information and intelligence support clinical practice. So in doing that, what I'm going to do is I'm going to take you through our journey of looking specifically at our National Antimicrobial Stewardship Programme in Scotland. And a little bit of background about myself. I actually spend half my week in Glasgow in an academic environment and half my week in clinical practice, leading up the national organisation in Scotland responsible for all clinical health information. What that does is include all prescribing information. So we now are able to, in Scotland, cover a population of 5 million and understand what medicines are being used and where at different levels of granularity. And it's based on this that we've started to look at, in this instance, antimicrobial stewardship. Can I just have a little bit more participation from the audience? How many of you, can you put your hand up if you're either involved in the procurement or supply of antibiotics, or in the actual clinical decision-making on which antibiotics may be given to a patient, or in counselling patients on those antibiotics? Hands up. A few. Okay. So for some of you, this might not have direct relevance. So I want you to think, as I go through the presentation, to think about, majority of us are probably pharmacists in this room, to think about, for the area of clinical practice or supply that you're involved with, that this development of information products to support care can be in any clinical setting. It could be in cancer, it could be in mental health, it could be in cardiovascular disease. And what I'm sharing with you is the journey that we've had in Scotland in the focus around antimicrobial stewardship. So just to start with, why are we interested in this area? Antimicrobial resistance is a global problem. This slide illustrates really the scale of that programme across and burden across the world. And looking at the European Union, that has a population of 500 million, that cost on an annual basis is over 1.5 billion euros. The slide also illustrates what the impact, both on cost and patient care, of poor management of antimicrobial use in other situations. So in Scotland, what we undertook was really to look at what was happening with respect to our use of antibacterials. And we noticed and examined that there was issues in variation in practice, including actually we could generate policies for antimicrobials and which antibiotics could be used, but actually they were not being adhered to. We could look at the wastage that was being provided in respect to antibiotics that were really unnecessary or inappropriate in those particular clinical settings. And also, are very aware of the consequences and the adverse impact of using those medicines, both in respect to clinical care of individual patients, but also in respect to a growing resistance patterns within Scotland. So within Scotland, we have a national strategy. We've just gone through a political decision to stay united as part of the United Kingdom, but we have health devolved. So within Scotland, we actually have our own NHS strategy and a quality strategy for that health agenda. That's based on the pillars, the 6 pillars of quality. And the programme that I'm going to take you through is really primarily focused on the safe, effective and person-centred elements of that programme. So if we think about that in the context of improving the intelligence that we give our frontline clinical practitioners, be those pharmacists, nurses, doctors, allied health professionals, what we're trying to do with the development of this intelligence platform is to be better provision of that data in order that clinicians can make decisions more rapidly and effectively for patients that